When we talk about issues of diversity and equity in multiple sclerosis, we're really talking about the fact that there is lack of representation and the possibility that a lot of our results don't generalize to the whole population affected with multiple sclerosis.
When we speak about diversity, equity, and inclusion, really what we're talking about is about building a humanistic healthcare system, where people with MS of all walks of lives can feel that they're truly being seen, truly being heard, and treated fairly, and that their own individual needs are being met. It's really clear that MS-DMTs should be considered basic healthcare for people with MS, and we need to make DMTs accessible very widely. Yet this is really an area where we see striking disparities across the world.
But what we are saying is that we need to pay attention to each individual and where they are, where they live, and what background they have as to how it may influence certain outcomes.
Hi, my name is Léorah Freeman, and I'm the medical director of the MS and Neuroimmunology Center at the University of Texas at Austin in the United States of America.
Hi, I'm Lilyana Amezcua. I am the Division Chief for Multiple Sclerosis and Neuroimmunology at the University of Southern California.
And I'm Brett Drummond. You're listening to the ECTRIMS podcast, the official podcast from the European Committee for Treatment and Research in Multiple Sclerosis. Multiple sclerosis is a global disease with almost 3 million people diagnosed around the world. This means that we have people living with MS from a variety of geographical regions who have diverse ethnic and racial backgrounds, differing socio-economic status, and an array of other distinct factors. This raises the question of if and how these differences impact on the lives of people living with MS. And have studies and trials used cohorts that accurately reflect the inherent diversity of the MS population to allow us to answer this question with an appropriate level of evidence? My guests in this episode, Léorah and Lilyana, presented on this hot topic at ECTRIMS 2024 and are passionate advocates for ensuring that there is a positive change in the current landscape of MS research to create a more diverse, inclusive and equitable system. Léorah, Lilyana, thanks for joining me.
Thank you for having us.
Thank you for having me.
So I guess as a way of framing the conversation from the very beginning, we obviously hear about terms diversity and equity a lot, but when we talk about that in terms of MS, what do we really mean?
So I'll start with that. When we talk about issues of diversity and equity in multiple sclerosis, we're really talking about the fact that there is lack of representation and the possibility that a lot of our results don't generalize to the whole population affected with multiple sclerosis. So for example, if we think about clinical trials, and I'm sure Dr. Freeman will be able to talk more about that, is that despite us having over 20 disease-modifying therapies, most of those clinical trials have focused the conduction and the outcomes on people of white background. There's also the lack of underrepresentation, even within observational data, where we don't know necessarily about their clinical characteristics and their MS outcomes and what specific factors lead them to have more severe disease. So in order for us to reach that health equity that we all want, we're going to have to be much more intentional about being inclusive and diversifying our cohorts, but also building strategies to make sure that that's happening. Because in many cases, these individuals that we're talking about that are underrepresented are racial and ethnic minority populations that are not necessarily aware that MS can be a disease that they're affected with. It also means that these are low income, there are low income populations too that are less reachable in rural communities. And those are also groups that have not been well represented. Nevertheless, I do feel that right now that diversity, equity, and inclusion sort of the language has been placed. And so people are wanting to know more about it. And so I think we are at a point that we could do better. And I'll let Léorah talk more about that.
Well, for me, I think when we speak about diversity, equity and inclusion, really what we're talking about is about building a humanistic healthcare system where people with MS of all walks of lives can feel that they're truly being seen, truly being heard, and treated fairly and that their own individual needs are being met. Overall, and I know I speak a lot about this when I talk about issues of diversity and equity, really central to this humanistic framework is the principle of justice, which should be embodied at every level, in our individual interactions between patients and clinicians, patients and researchers, but also at the systemic level and at a global level.
Yeah, and I think that definitely really came through in presentation at ECTRIMS 2024, and I think what also came through really clearly in both of your presentations, the presentations in the sessions, is that these issues, that they're issues that affect every part of a journey of a person living with MS, and starting from the very beginning in terms of diagnosis. And I was just wondering, whether you could share some thoughts around starting at that very early time point. What do we know around the differences that exist, especially in some of these minority populations, around difficulties around receiving diagnosis and some of the issues about that?
Yeah, so for example, if we are just focus on racial and ethnic minority populations, and again, these could be also remote rural communities, and so we know that there are diagnostic delays. So these diagnostic delays may be a reflection not only of the patient not being aware, but also about physicians and healthcare providers that perhaps are not thinking MS in their top differential because of prior, sort of knowledge, and we all believe this, right, that MS was less prevalent in certain communities. And so that's one. So it creates this sort of like bias or unconscious bias that they should be looking for other explanations before they reach the possibility of multiple sclerosis. Other things that complicate, the issue of diagnosis of MS is that, for example, the disease and the differential has been focused on the characteristics of white people. And if that is so, then we are missing out some of the clinical characteristics that could be, that are much more common in certain populations. So, for example, individuals of Hispanic background are twice more likely to present with optic neuritis. Optic neuritis in itself, as having, for example, a lesion in the optic nerve via MRI, may not count for the diagnostic criteria. Of course, the future of the diagnostic criteria might change now, and this would mean that perhaps now we'll be more able to include those individuals that present with optic neuritis. And so that is, for example, an important characteristic that we did not know about that population and could be important in terms of even just how we diagnose MS and the validity of the diagnostic criteria. So I think, knowing those characteristics is helpful, but it's also understanding that MS is a global disease and can affect everyone. And so I think the provider needs to be more aware that MS can affect these populations, and for example, optic neuritis, or maybe they're presenting with a much more severe disease because of the time that has lapsed between that first symptom and the time to when they got to that diagnosis.
Yes, I think that there is kind of often this lack of awareness that is a barrier to care. There's also issues that have become more and more discussed in our community, such as the issue of medical gaslighting, that I think disproportionately affects people from certain population who may not be believed for their symptoms, who may encounter clinicians who will not listen to what they're going through and what they're experiencing. So really being able to combat our own biases is very, very important, and being able to listen fully to our patients to guide them on their journey. I think there are also some issues related to the different healthcare journeys, pathways of people from different population. Somebody who may come from a rural community may not have access to a neurologist as a first line if they experience any symptom. They may be seen at a local, urgent care center where they MS is not even on the differential. And something that, I think we have to watch, there's a lot of excitement at ECTRIMS, and rightly so, about the new MS diagnostic criteria. I think we're going to see a lot of improvement in the accuracy of the diagnosis of MS thanks to these new diagnostic criteria, but we have to be very careful about the implementation of those criteria in practice, looking at these criteria require access to even more technology, just MRI signs that, may not be visible on a typical MRI acquired in a rural community, or other biomarkers that people may not have routinely access to if they are not seen at a big MS center where they can see people who are very knowledgeable about this. So we have to take these issues when we implement our diagnostic criteria going forward.
No, Léorah, I think you bring out really important points that I think are so important, that, there are the patient factors, right? And then there's the physician and the system base, and every region is different. And we certainly know about, for example, low and middle income countries that may not have access to an MRI in every place. And if the diagnostic criteria is really set on much more high level imaging, right, including pearls and central vein sign, then we may have a big problem there. And so, while I'm really excited about the new diagnostic criteria and the accuracy, is what do we do about those settings? And it's just food for thought for us, right? As individuals, how should we protect and make sure that the health disparities do not widen in those regions? I think it's going to be really important. And then just one last thing about patients is that, from the patient side, what we are really talking about is social determinants of health, whether it's, that gaslighting from physicians, because that individual has a lower education, right, and is not able to perhaps express the symptoms, right, or linguistic issues. And how do we develop, sort of, or implement effective programs to help with those issues so they can make sure that they are not ignored?
Yeah, and I think when we talk about this, and Léorah, you did a really nice job of sort of framing your conversation around this during your presentation at ECTRIMS 2024, is the importance of making sure that populations aren't left behind in terms of diagnosis, and we're not getting this diagnostic delay, is critical with, evidence that we've generated, especially over the last 5 years, showing, how different long-term outcomes are when we can get a person living with MS onto a high-efficacy therapy as early as possible. So can you talk to us a little bit about this, but also what we know about access to DMTs around the world and in some of these different populations?
Yeah, no, absolutely. I mean, if there's an area that has me in awe, is the advances that we've seen in disease-modifying therapy. In the 15 years that I've been in practice, I can truly say that the advances have been remarkable. I remember the days where most of our patients were on platform therapies, and we had so many patients come in for relapses on a daily basis. And now that, we have access to high efficacy therapy, there are incredible changes in outcome. And research really shows this. I think a number that I cited during my ECTRIMS presentation was that continued treatment with MSDMT reduces the need for a working aid by 67% over 15 years. So really, when we look at numbers like this, it's really clear that MSDMTs should be considered basic healthcare for people with MS. And we need to make DMTs accessible very widely. Yet this is really an area where we see striking disparities across the world. And a lot of what we know about world access to disease-modifying therapy comes through the MS International Federation Atlas of MS survey, and really encourage everybody to read this. It's very enlightening about what's going on worldwide with MS, because we tend to be very focused on what happens in our backyard, and so worldwide we really see very wide gaps in care, So looking at access to licensed DMT, worldwide, about 14% of countries do not have access to licensed DMT. But when we look at low-income countries, that number increases to 70%. When you're looking at high-efficacy therapies, the disparities are even larger. 100% of low-income countries do not have access to these treatments. But it's even important to remember that even when a drug is available in a particular country, that doesn't mean that this drug can be utilized. As we talked about, to for people to be able to have access to disease-modifying therapy, you need not only the medication that's available, but you also need, prescribers that are trained to be able to prescribe this medication, to be able to monitor it. You need to have a system that supports the payment for these disease-modifying therapy. And we see incredible difficulties for governments or insurance providers in lower middle-income countries to be able to provide these medications. So we have large swaths of the population that cannot access these treatments, even in countries where they are quote unquote available. So we have to be able to come to a place where really truly DMTs are made much more widely available for people with MS, because the changes in outcome are so significant. I don't know exactly how we can do that worldwide, but we can certainly start studying, in each country or region or area, the determinants to access, to be able to bring access to these medications more broadly.
No, I mean, I couldn't agree more. I think, but it is a start, which is really exciting, right? To just be able to have, or at least to suggest that every country should at least rituximab, right? Glatiramer or acetate and cladribine, right? As 3 drugs that should be available. But are they, like you said, really accessible and affordable, right? Because in many cases, when we're talking about the issues of DMT inaccessibility, it's really reflective of the low middle income countries that are not necessarily have, universal healthcare systems, right? So that means that the individual, the patient, needs to be able to pay for it somehow. And we just don't know the cost of those drugs to each country, and each country is going to differ. And it may be a lot of money where it might sound very little to the United States and may be the whole income of a patient for that month. So I think maybe it starts with an analysis, just like you say, and looking at other existing programs. I don't know how it is for diabetes and insulin, but is that something that's universal? But maybe we can learn from other diseases.
Yeah, definitely. And I mean, I think probably one of the first steps, as always with these things, is starting to raise awareness and having the discussions. I mean, we can't fix a problem unless people know that a problem exists. So I think, starting with this podcast and having you both share your insights into this is a good first step. Because I think moving on, obviously access to DMTs is one. You talked a little bit at the start around how some of these different factors can affect clinical outcomes. I'd love for you to share a little bit in terms of what we know around how some of these different factors, including social determinants of health, can actually influence clinical outcomes in people living with MS.
Yeah, so I mean, when we talk about clinical outcomes, we're talking about whether it's a timely diagnosis, right? Or whether it is disability, right? MS-related disability, be it ambulatory or cognitive. And what we have seen that, in respect to worsening, or what we think worsening cognition is, when we look at, for example, Hispanic, African American compared to white, where we thought that it's related to the disease, it's actually best explained by, different levels of education and different levels of socioeconomic status. And so what we're trying to say is that, it is not an issue necessarily of race and ethnicity as biologic, right? Because race and ethnicity is a social construct. But what we are saying is that we need to pay attention to each individual and where they are, where they live, and what, background they have as to how it may influence certain outcomes, meaning how they do in the cognitive test. Or is it that that worse disability is because there was an initial diagnostic delay? And do we take diagnostic delays, for example, as an issue in the outcomes in a clinical trial? No, everybody sort of starts in the same, and you hope that the randomization just, eliminates that. But meaning when we consider actually including these populations, we're going to have to pay attention to those issues. And the places that we are seeing this is, for example, in the CHIME study, which is a phase 4 clinical trial that is looking at Ocrevus in the treatment of African American and Hispanic people. And we can already start seeing that baseline characteristics differ than what the original cohort of OPERA was, which is the original ones for Ocrevus that was mostly white people. And we see that, for example, they are starting off with higher number of comorbidities. And we all know that comorbidities are important factors in MS that can, put you at higher risk of higher disability. So that's going to be certainly something for us to consider. But then, of course, when we even are thinking about the diagnosis and the differential, we know that social determinants of health can influence, like I said, how you get to the doctor and how the process of the whole, collection of data may be impacted, which may lead to diagnostic errors. So, for example, with our fellows and residents, whenever I hear somebody say, oh, the patient is a bad historian, I cringe because I worry. It's like, no, nobody's a bad historian. It's just inability to gather the data correctly. And maybe the individual has a linguistic or lower education, lower health literacy, basically, to be able to fully tell you the story. But one thing that we just need to do is consider those factors and how they impact our diagnostic capabilities and outcomes.
Yeah, and I couldn't agree more. I think that when we talk about social determinants of health, it's really about, us being able to really dive into the sometimes chaos of people's lives and being able to really understand what's happening in their life. How do they live? What do they have access to? Do they live in a neighborhood that's not safe for them to walk around or exercise? And really getting to know the whole person. It's a complete different mindset in medicine, I think, than just looking at the disease and treating the disease. We're looking at the whole person and trying to create a system of care that addresses all the challenges that these individuals go through. Liliana talked about comorbidities. This is a topic that's definitely a very important, for me living in the South, in Texas, and we see clear disparities in comorbidities, and we know that these social determinants affect, the prevalence of those comorbidities. We know that our Hispanic or Black patients or patients that have low socioeconomic status that live in rural area will have greater comorbidities, and we know that these comorbidities will lead to faster progression and sooner use of walking aids. So what can we do? We have to ask ourselves, how can we transform care for people with MS so that we can address not just MS, prescribing disease-modifying therapy, giving people symptomatic treatments, but also take care of the whole person, developing new programs that can help us address those social determinants, questions of access to care, address these comorbidities in dedicated programs where people can be engaged and empowered to make change, in a way that is culturally sensitive. I think there's so much we can do when we really look at the whole person and not just a disease.
I think what's really interesting is that it's very common to hear people say MS isn't the same in any two people. What we also need to be thinking based on this is no two people living with MS are the same either. So we need to look at that in both ways. The disease isn't the same in individuals, but neither are the individuals the same. Question that I think is, well, maybe not difficult to answer, but one that we could certainly answer at length. I'm going to get short answers on this because we have a few other things to talk about. In both of your opinions, do you think at the moment that the data that we have coming out of trials and studies is reflective of the general population of people living with MS, or do you think it's not representative around some of these extra populations that we're talking about and the diversity that exists?
There's starting to be a body of data showing this. I think we have an underrepresentation of people from, racial and ethnic minority. We certainly have entire part of the world, like Africa, for example, that's entirely excluded from clinical trial. And it's not just clinical phase 3 trial, it's also observational cohorts. We need to do better at developing, research programs that are truly inclusive to be able to have, an understanding of the diversity of MS and the diversity of people with MS.
Yeah, I agree. We are not there yet. The foundation language has been set, but the actions are not there yet. But I think we're in a big, nice position now because people are listening for us to move forward with creating strategies, right? And how we're going to get that representation that Léorah just mentioned that is so needed is that we're going to have to develop facilitators at the onset or preconception, at the conception of the clinical trial, and not just wait for the barrier to happen as the clinical trial has been executed and then say, oh, you know what, we're having trouble recruiting Black people and we're going to now implement. No, it has to be at the conception and seeing these are individuals that require this based on population data. We know every individual requires something different, but at the population level, if we install these facilitators, we are more likely to recruit and retain, and then we're able to, be inclusive. Because right now is, and again, not just diversified, but inclusive. Inclusive means that we need to hear the voices of the populations not represented.
I think I would have been surprised based on what we talked about to this point if your answer to that last question had been yes. So still a little bit of a way to go, but it's good that we're having the discussion. So I guess to finish off, we could obviously talk about this for hours, and it's such an interesting and important topic. But to finish off, if you could give a couple of key messages to researchers, to neurologists, to policymakers around the world about how we can change things to improve the lives of all people living with MS, because I think that's where we started the discussion as what our goal is here in terms of, improving this. What would those messages be?
Lead from the heart. I tell my trainee and anybody who would listen that, justice is not just a societal principle, it's a personal virtue. Start with you, how you look at people around you, how you care for them. Really just approach, your patients, your research participants with curiosity and love. This is where it starts for me.
And I would say it's not just a matter of justice, but it's a matter of our patients. It matters to our patients. And I know it matters to all of us, but if it matters to our patients, we need to do this. Yes, it's about getting to know them. And it's not just them that moment, but everything around them. And that will open up everyone to realize how important it is to include all these other societal aspects and be able to understand MS in every population.
I think those are perfect messages to finish on. Léorah, Lilyana, I want to thank you both very much for sharing your time with us today, but also sharing your insights into what I said is such an important topic and one that I think we're going to see continued to be discussed and hopefully continuing to see more and more action taken on so that we can achieve the world that we're all hoping for.
Yeah, thank you so much for shedding light on this important topic. And I think Lilyana and I and the entire group that presented that session was so excited that, ECTRIMS is raising the volume on this issue. Thank you.
Thank you so much.
And thanks everyone for listening. Once again, I'm Brett Drummond, host of this podcast episode and co-founder of MSTranslate, an independent resource centre that aims to simplify the complex wealth of information about MS for the greater MS community. The ECTRIMS podcast is produced and hosted in collaboration with two key partners, MSTranslate and the MS Journal, a peer-reviewed international journal that focuses on MS, neuromyelitis optica, and other related autoimmune diseases of the central nervous system. The 2024-25 ECTRIMS podcast series is supported by educational grants from educational grant providers, including Alexion AstraZeneca Rare Disease. Educational grant providers have no input in the podcast content. You can read more about the topic of this latest podcast episode and more on the ECTRIMS website, ectrims.eu. Do subscribe to the ECTRIMS podcast on your favourite podcast channels and follow ECTRIMS on X, formerly Twitter, LinkedIn, Facebook and YouTube.